Hello, everyone, and thanks for joining us again for another episode on Heart Trending YouTube channel. This is Chadi Alraies coming to you from D2 Medical Center. I'm really privileged to come to you with a new paper published from our research group related to a very important and yet clinical question for patient coming to the cath lab with acute coronary syndrome. I'm really privileged to be with Ryan Berry, who's a lead author, who has been doing a phenomenal job on this paper, and also with Khaled Harmouch, a second author, and also collaboratively worked together along with a team listed on the screen here to publish this paper successfully at American Journal of Cardiovascular Drugs. The title of the paper is Morphine and P2Y12 Inhibitor and STEMI Patients, an Update of Meta-Analysis. Dr. Berry, Dr. Harmouch, thanks so much for being with us.
Thank you, Dr. Alraies.
Thank you, Dr. Alraies.
Yeah, so I'm going to jumpstart the discussion by asking Dr. Berry tell us about where this question came from and what is your hypothesis?
Yeah. So, as we all know, heart attacks are painful events, and we typically use opiates, in particular morphine, to give relief to these patients. But despite it being historically a Class 2A recommendation, it's not necessarily grounded in studies that have evaluated efficacy relative to some standard. So it's been more about general agreement. And ever since there was a Crusade initiative, which identified that there may be adverse events related to opiate use, there's been renewed interest in whether or not our use of this pain reliever actually imposes harm. Accordingly, we reviewed some of the literature so that way we can get a sense of, okay, how grounded is this claim?
That's again a very important topic because again in the main combination for management of patient coming with ACS, it's called the MONA, which is morphine, oxygen, nitro, and aspirin. Now with this opiates and the impact on gastric emptying, again, this is kind of changing the algorithm a little bit. So Khaled, I will jump to you, Dr. Harmouch, again to tell us about what is the main result or what is your search strategy and what was the main finding and how many articles you found that talk about the same topic.
Absolutely. First of all, thank you, Dr. Alraies, for this great meeting and opportunity. It's my pleasure to be part of this awesome work, and big thanks to Dr. Berry as well for this awesome job in publishing the paper. So as Ryan, just to add up on what he said, as you just also said, Dr. Alraies, so MONA was always something that we studied in medical school when you are just dealing with STEMI or ACS in general. That's what M stands for morphine. But also, despite that, pharmacokinetically or pharmacologically, knowing that morphine and DAPT, in particular PY212 inhibitors, can be kind of altered metabolism-wise by this medication. So we kind of opted to see how people did, those who presented with ACS got morphine versus those who presented with ACS who didn't receive any morphine but received placebo instead, and wanted to kind of compare the clinical outcomes and see which group did better in that sense. General, we conducted just a systematic review and meta-analysis. In general, we screened over 979 or 978 articles to be more specific, looking for article systematic reviews and looking for randomized clinical trials, actually comparing ACS with morphine or ACS without morphine. And then we actually ended up screening thoroughly and then based on our search criteria. And then we ended up with 7 articles. And then the results, actually, the clinical outcomes initially the studied were many. We had TIMI score 2, TIMI score 3, we had the infarct size, post PCI MI, post-procedural bleeding, all-cause mortality. So actually, surprisingly, the only significant or clinical, I would say, statistically significant value or variable was the decrease in TIMI-2 score compared in the morphine group compared to the placebo group, while all other studied outcomes showed no statistically significant difference between the two groups, the morphine and the placebo. And then I'll leave discussing these important findings to Dr. Berry, who did a great job on talking about it in his discussion. So Ryan, would you like just to kind of enlighten us about what do you think of these outcomes and what are the results?
Yeah, and because I mean, you've been so generous. Really, me talking about the data isn't anything with it being collected and being coordinated. So thank you so much, Khaled, as well as the others who are actually not even on this call. That being said, with the bulk of the data that we had, an additional trial and some cohort studies since the last meta-analysis was done, particularly the Atlantic study, which contributed to our findings, we found that there was a significant association between morphine use and decreased frequency of TIMI2 flow after PCI. But we didn't find any changes clinically. And so then there's this discrepancy between what we see radiologically, which is a decreased frequency of TIMI2 flow, with no corresponding effects between groups, those that received the morphine and those that did not. And so there was question about whether these radiologic findings are just that much more sensitive, and then also what they really mean, because despite seeing a decreased frequency of TIMI2 flow, there was no corresponding percentage increase in either TIMI3 or TIMI1. There were some non-statistically significant findings of increased TIMI3 flow, but it's hard to draw a conclusion. So despite all the sort of attention that's been renewed in morphine use as part of the MONA treatment that we typically were taught in medical school, there doesn't seem to be any corresponding clinical evidence that we should have the degree of concern that was initially sparked by this line of study. And so I hope that puts us at ease in terms of our use of morphine. I don't think anyone's going to stop using it just because of this necessarily, but at least it gives us some peace of mind.
Absolutely, and this is a very important point, especially with worry about gastric emptying or delaying of or inducing a transient gastroparesis in patient who's coming with a STEMI. There is a famous picture with Michael Gibson. He put usually the Plavix kind of tablet stuck in the stomach wall while they're doing angiography. Not because of morphine, but usually in general, when somebody is in shock, there's a kind of decreased motility, decreased perfusion to the gut, so decreased absorption. So I think also the selection of P2Y12 inhibitor is very important. And lately we have noticed kind of a lot of shift towards ticagrelor instead of clopidogrel. From both your experience, I mean, you work in different ERs, you work with different ER attending, as well as receiving these patients to the ICU when you are in ICU. Have you noticed that there is increased shift of P2Y12 inhibitor toward ticagrelor compared to clopidogrel?
Well, just speaking on here, I'm doing my residency in one of the Detroit hospitals, and actually it's always Plavix and clopidogrel and aspirin. Ticagrelor I've seen it being used in a very, very few cases, but the majority just end up, we get the patients from the ED, they're already loaded Plavix and aspirin in most of the cases, actually.
Yes, and also, I would say that I'm with Khaled in the sense that I've seen historically more clopidogrel, but I have seen an increased use of ticagrelor, and I think part of it initially, the reluctance is comfort, but also it seems like the practitioners I've worked with also had concerns about coverage. I think Khaled could speak to the fact that we don't necessarily have patients who always have the blessing of receiving brand name coverage, especially when a new indication or benefit of a drug comes to fruition.
Yeah. Okay, I would like to thank you both for a great, again, meta-analysis, shedding the light on a very specific topic for patient presenting with acute coronary syndrome. I'd like to congratulate you both first for work well done with also other authors like Dr. Ala Roto, Nomesh Kumar, Zubej, Risha, Muhammad Hamza, which has contributed a lot to the analysis, Dr. Yasmin Bahar, Yasar Sattar, Wal Jarudi, Timir Paul, and the team kind of put together a wonderful kind of illustration of collaborative work that we do it on our research group on almost weekly basis. Congratulations again for both of you for a paper well done. Please stay tuned for more videos coming to you YouTube channel. Dr. Harmouch, Dr. Berry, thanks you again for being with us.
Thank you so much.
Thank you both.